In the late 1960s, early 1970s, many studying physiotherapy had the opportunity to take up bursaries from the Department of Health. This meant that you could be sent by the department to a hospital anywhere within New Zealand where they required a physiotherapist. The people were sent, for example, to the West Coast, to other smaller centres rather than the big cities. I wasn't on a bursary and applied for a junior post with the Canterbury Hospital Board and was offered a place at Christchurch Hospital. I can recall rotations in general outpatients, ultraviolet light, neurology. And neurology had not been of special interest to me, but again, working with the experts in that field, including Margaret Draper, it was very exciting too. After 18 months, it was possible to ask for a transfer to the Princess Margaret Hospital to continue my interest in cardiothoracic work, and this was granted. But before then, I had had some experiences for which I'm most grateful in general outpatients. I remember the Welsh rugby team arriving on one occasion because in those days the teams didn't travel with their own medical support or their own physiotherapist, and they used the physiotherapy departments of local general hospitals. We were, or as new graduates, were rather taken by these handsome young men stripping in the department, but I can't recall any long-lasting liaisons with the players. Miss Joan Durbridge was in charge of the department, and she was a wonderful person, very quiet and unassuming, but extremely astute, and someone who took great pleasure in the achievements of her staff rather than in her own personal achievements. I was asked by Miss Durbridge to undertake a small study looking at nerve conduction using equipment on loan from the Department of Physical Medicine, that of clinical electromyography. And this led to the presentation of a paper at the biennial conference of the New Zealand Society of Physiotherapists in that year, and my first publication in the New Zealand Journal of Physiotherapy. And this was an amazing start to my professional career, and looking back was what put me on the track of research and teaching and further publications. I also had the opportunity, while in general outpatients, to look at some case studies which Miss Margaret Draper had undertaken in patients with Bell's palsy, and in helping her the analysis of that data. A combined paper, I think largely written by Miss Draper, but she kindly and generously put my name on it too, that was published in the New Zealand Journal of Physiotherapy. So with that background, I then moved into the cardiorespiratory world at the Princess Margaret Hospital as a junior physiotherapist rather than a student, and worked more closely with Heath Thompson and with Jill Miller. The physiotherapist was very much a part of the cardiothoracic unit. Heath had what would today be called the multidisciplinary team. That comprised the two cardiothoracic consultant surgeons who had the background of both had backgrounds of physicians, which was to the patient's benefit, The consultant radiologist, the registrar, the houseman, the senior nursing sister, and the physiotherapist. Officially, our day began at 8 o'clock, but it was important to treat the first day thoracotomy patients before their 8 o'clock chest x-ray and before the 8 o'clock ward round. So we would see the patients would have their first treatment before their x-ray, before the ward round, to make sure that we had optimised their condition for the day. We then joined the ward round, went round all the patients, and then moved to the Department of Radiology, where the x-rays, which would have been taken during the time of the round, were inspected and read by the radiologist. And if there was so much as a shadow on a lung, we would go back to the patient and deal with that. And that was an amazing environment to be in. There was also a regimen for the thoracotomy patients of being seen in the recovery ward on the day of their surgery. They would be sat on the side of the bed, their data monitoring being in accordance with repositioning, and then put into the sitting position. And that was the beginning of 2 hourly turns for these patients. If someone had had a left lower lobe resection, they would be nursed in right side lying, which, of course, we now realise was to optimise the ventilation and perfusion to the good lung. And that did, of course, improve their gases. But they were not being continuously monitored. They would be monitored once a day with blood gases being taken, rather than the non-invasive monitoring of today. 2 hours later, that patient would be moved from the sitting position back to side lying, and that continued during the night and during the day. On day 1, they would be standing and ambulation would begin. So it was the beginning of the recognition of the importance of ambulation and the importance of positioning to improve ventilation and perfusion to optimise lung function. None of this was coming from the literature at that stage or from medical guidelines. It was all Heath's clinical ability to identify what was appropriate for his patient. He would be on duty 24 hours a day, 7 days a week, and only occasionally took a holiday. If a patient was about to go off, as one would say, he would have identified that long before any monitoring equipment picked it up. As the years went by, he became a little deaf, and I recall the ward rounds when we could get away with a little bit of social chat in the background. But unbeknown to us, he suddenly started to wear hearing aids and soon tuned into our conversations, and we either had to include him in them or bring a stop to them. It was more appropriate, of course, to bring a stop to them, and I think that is what we did.